Hey guys, what's going on? I'm going to try and make up for missing some lab time last week and this week here. So this is a video I'm going to try and walk you through as far as how to approach trach care for a patient. I'm going to try and move this guy a little bit closer so you can see a bit better here, maybe. Okay, trach care is something that everybody does maybe a little bit differently. I'm going to kind of streamline this, give you a very easy approach to doing trach care. Trach care is something that should really be done probably once a shift. I like to take good care of my trach patients. There's times where somebody has a stoma, an opening where their tracheostomy tube's going in that is exceptionally dirty or got a lot of secretion. Sometimes I'm doing trach care every assessment, just site care and keeping it nice and clean and dry to prevent it from kind of getting gross and everything like that. So with me trying to shoot this video using my laptop so I can see what I'm doing, obviously I tried to write some stuff up there on the screen and it is all backwards. But essentially I break down trach care into really 3 steps, but I'm going to add a couple other little things in here. Obviously, anytime we go in to see a patient, we're going to do an assessment. It gives us a good baseline for your trach patient. You want to know, do you need to suction this patient? The last thing you want to do is start manipulating that trach, get all your area clean, change out your stuff, and then they have a bunch of goobers and they cough it up and they dirty up your work. So performing a little bit of an assessment, doing site care, which is actually removing the old drain sponge, and I'll kind of talk more about what that is. Cleaning up the site, and we'll talk more through that. We're going to go ahead and run and change the inner cannula only if applicable. All right, so your Shiley trachs are typically the ones with the removable inner cannula. There's some other ones out there. Bavonas do not, so that step would be null and void. Then lastly, I like to go ahead and change the dressing and the ties, okay, and I'll kind of walk you through that. So getting everything clean, changing everything, and then the last thing you always obviously want to reassess and everything like that. Okay, so we come in, we'll be talking to our patient, standard precautions, everything like that. We're going to go ahead and do a little bit of an assessment here. Okay, so I don't have my stethoscope. I'd be listening to breath sounds, talking to the patient. A lot of times having them take a deep breath, see if they can give you a good strong cough. And that lets you know if you need to get this guy suctioned out. Okay, so let's say he does sound gurgly and I want to go ahead and I don't want to dirty up my work or anything like that. I'm going to go ahead and suction. And I'll walk you through, once again, a little bit of basics of open trach suction. You'll know your patient, okay? We should consider hyperoxygenating, especially if you got somebody with marginal saturations. I got our guy on a trach collar here, so all we could end up doing, if you're worried about that, we should have him on a monitor. I could increase my FiO2 by turning the venturi back here on the trach bottle. And remember that you're going to have to increase that flow rate to give enough total flow to meet that patient's needs here. Okay, while I'm kind of getting this guy all ready to go and everything like that and getting his oxygen built up, I'm going to go ahead and be meticulous and make sure I have everything I need. You want to make sure you have suction set up. I'm adjusting that vacuum pressure to no less than 150, and that is, I'm adjusting. Let me dial this down here a little bit. I'm adjusting while I actually have my thumb on that control or on the tip of the suction tube, and that gives us an accurate idea of how much pressure is going to be exerted on that patient's trachea. Now, I don't like to live dangerously, but this tubing would either be longer or I wouldn't be pulled so far away from the back of the bed. You want to make sure that connection is on there firm. All right, I'm going to get into my sterile gloves here in a second, and it never fails. If you don't check the connection, something's going to break off after you get your sterile gloves, and you can kind of throw a little wrench into things, okay? So while he's hyperoxygenated here, I got my suction all set up. I've already done assessment. I take the gloves off before I put my sterile suction gloves on. Sometimes if I'm dealing with a latex sterile suction glove, I will leave the gloves on because I can't stand the white powder. Totally your call, okay? Every suction kit's going to be a little bit different. I've already told you I'm not a big fan of these particular ones here. Okay, it's not the nicest ones. Some of them are labeled left and right when you open up your kit. Okay, these ones are not. So I'm going to go ahead and fold my kit out. I like to bring a bedside table can. I'm going to go ahead and I'm going to open up my little sterile basin here because we'll actually use that for pouring some sterile water into. Okay, we're going to go ahead and open up our kit here. These ones don't like to stay open really well, so I'm grabbing at the flange, making sure I'm not touching anything. Once again, you'll notice that all the gloves here are going to have their cuff kind of rolled over, and that gives us something to kind of grip onto. I always start with putting my non-dominant hand glove on first, and notice I'm not touching the glove. I'm only grabbing that rolled over edge, and I get a finger underneath it and kind of work that glove down, okay? This glove is still sterile, so I can go ahead and I can touch this glove, although get in a habit, I put my fingers back behind that folded edge there. The biggest thing people mess up on is we talked about an NT suction. They try and put this glove on and they're touching their glove to their wrist and everything like that, and you really lose sterility. You want to keep this thing as sterile as possible for as long as possible, okay? So all I'm doing here, I'm getting it started, and you can see I'm not touching my skin. I'm only touching the outside of that glove. As of right now, both my gloves are still sterile, okay? I'm going to go ahead. I'm going to get my suction kit out. Once again, not the biggest fan of these. I can touch everything inside of here because it's still sterile. Okay, I'm going to go ahead and I'm going to get rid of my little paper here. Once again, I like to always assume control of that tip that's going to be going down into the trach, so I go ahead and I wrap that in my dominant hand. Both hands are still sterile at this point, although my non-dominant hand is going to lose sterility here. All right, so I'm going to go ahead, not sterile anymore. I got a little bit of sterile water, okay? We're going to talk more about this sterile water, and we're going to use it during our actual site care. I like to pour it in the basin here. Some of your suction kits are going to come in like a hard plastic shell. I'll pour water into there. You can also get a little sterile medicine cup and pour a little bit of sterile water in. All right, so this hand is no longer sterile. Sorry, I got a beard here in my mouth. All right, so I know I'm not going to have two sterile hands because I got to touch this dirty suction catheter. Pressure's already checked and I'm ready to go. Put my patient hyperoxygenating here, and once again, ideally I'd have them on monitoring. I'm not putting my thumb over that little hole in the control port just yet, right? I'm going to wait until I get down there. I like to pull the trach collar just kind of down beneath the trach. You can pull it off to the side or above or whatever. I like to keep it nearby, but sometimes, depending on your patient's chest anatomy, if you pull it down, that thing's going to pop up and you're more likely to hit your catheter here, okay? So I'm going to go down. I'm going to make you cough a little bit. I'm going to get some stuff up and out of there. Words of wisdom, always staying off to the side, never look in the direct line of sight here. You don't want to look down that patient's trach, and you always want to stand off to the side while you're doing this. Obviously, consider wearing all the personal protective equipment that you deem essential. Not a bad idea to wear a face shield or glasses if you got somebody that you're worried about being a real sprayer. So I now am being very, very conscientious about when I put the tip in this trach here, okay? I don't want to go around the sides and miss the hole, and because I'll lose the sterility of that trach or my suction catheter before I go into the trach. I'm going to slowly advance. Okay, notice I'm keeping my hand kind of away. That way I'm not touching anything. I'm going to go ahead. I'm going to push until one of two things occur. I meet a significant amount of resistance, and that could be us coming out of the end of the trach, hopefully, and into the patient's airways. All right, it could be a mucus plug. We'll talk more about that in airway troubleshooting. Or I advance this until I get a little bit of a cough. Once I get a cough, or if I'm meeting that resistance and I really think I'm outside of that patient's tracheostomy tube, I go ahead and I pull back about a centimeter to make sure that I'm not latching onto that tissue whenever I apply my suction pressure here. So I pull back. All right, I'm going to go ahead and put my thumb over the control port. Watching the patient, watching monitoring. I'm giving a gentle little twist while I'm down there, okay? Not wanting to stay down more than 15 seconds. 15 seconds is a long time, all right? So you can hold your breath when you're getting used to all this. But I'm going to go ahead. I'm going to try and make the most out of my pass, all right? Then I'm going to go ahead. I'm going to withdraw. As soon as I withdraw, I quickly wrap my hand around that tip, and I place them back on the oxygen, okay? At this point, I'm allowing that patient to recuperate. I'm allowing them to kind of get their oxygen back up, catch their breath. If I needed to clear my suction catheter, I could do so. I use my little sterile basin, just sticking it down and in, and that kind of flushes that, gets it all cleared out, makes it a little bit more successful on my next pass. Now I give them a minute or two to kind of recoup here. I'd ask him to take a big deep breath and give me a big strong cough, or if he sounded like he was still gurgly even without doing an assessment, I could go back down again. All right. At this point, if we were just suctioning him, I would go ahead and I'd wrap my catheter, take off my sterile gloves like I showed you for the NT suction, and that'd be that. I'm going to leave these on as long as they're not too gross. Sometimes I will take them off and put on regular gloves. Okay, I'm going to try and conserve PPE with all the COVID stuff going on. So I'm going to go ahead and drop that right here. Move my suction out of the way. I don't need these gloves to be sterile during trach care. All right, I'm just going to do a little bit of site care and everything like that. So I'll address that patient's oxygenation here at the very, very end. I'll leave them kind of bumped up for the time being, just because I'm going to be kind of moving that trach collar away. Most of your patients are tolerated just fine. You do want to be conscientious that if you're taking that collar away from the patient. Okay, so I always start with if these ties are too tight, I loosen them up just a little bit, and it's just a little bit of a Velcro strap. And you don't want it too loose so they can cough that thing out, but sometimes it makes it easier. We're going to go ahead and we're going to pull that old drain sponge out, okay? You don't want to throw that away. I like to take a look at it. I like to inspect the stoma a little bit. So I kind of pull that flange, look back behind, make sure there's nothing alarming, no signs of infection, irritation, redness, any of the things that we're kind of concerned about, okay? So right now that stoma is dirty. I need to get this thing cleaned up and out of there. So the preferential substance for using or for performing site care, stomach care and everything during trach care is sterile water. Okay, you work with some old school people and stuff like that. And I've even I remember learning using hydrogen peroxide around the stoma side to kind of clean everything, and it's good at debriding stuff. It's irritating to the stoma, so we do not use hydrogen peroxide as general rule of thumb anymore on routine trach care. If you got a funky trach and the flange has got blood on it or anything, you can use hydrogen peroxide, and it's really good at moving stuff off that trach, but it shouldn't be really applied to that patient's stoma. So the things we're going to need here, you're going to want a replacement set of trach ties. Okay, I already got my sterile water. If you get a jug of sterile water at the hospital, there's going to be a procedure. Usually you got to write the date you opened it, and it's only good for so many days afterwards. Once again, you can pour it into this little basin, or you can pour it into a medicine cup. In a pinch, I always have pink saline squirts in my pocket. These will work as well, okay? And it's not going to cause any harm or anything to that patient's tissue. Sterile water is preferential. If you don't have access to it, or if you're in a hurry and just doing some routine site care, pink saline squirts work just fine. 0.9% saline. It's not going to cause any problems. You can either use gauze 2x2s or gauze 4x4s. And usually we're leaving stuff for the next shift, so you'd have an abundance of supplies. I like to keep a little plastic basin with all my trach care supplies and stuff like that in there. Okay, I'm going to use 2x2s. If it's a really gross one, you're going to use a lot of 2x2s, or you can go to the 4x4s. It's just a matter of kind of what you have access to and everything like that. So we're going to start with doing some routine site care. And this is not a sterile procedure, but we're trying to not, our whole scope is to prevent pushing nasty stuff from the skin into the stoma. So everything is actions away from the stoma as we're cleaning things. I'm going to take my little gauze 2x2. I like to fold it over here, okay? If you're at a 4x4, sometimes I'll do like a double fold. And all I'm doing, I'm going to dab it, get it a little bit wet in the sterile water, okay? I'm going to go ahead, move that patient's trach collar here for a second. On my stoma, I like to try and think about it as putting a set of crosshairs in the middle of it, breaking it into 4 quadrants. Each quadrant, I'm going to do one wipe away from the stoma. All right, look at my gauze and then flip over and use a different clean part of the gauze, or a different piece of gauze altogether, depending on how gunky it is. So I'm going to go ahead. I'm going to pull that flange out just a little bit, and I know you probably can't see really well. I'm going to pull that flange out just a little bit and just get really, really close to the stoma and wipe with a little bit of pressure out and away. I'll take a look and go, oh yeah, there's some stuff on there. I'll go ahead and I'll fold that over. Now I got another semi-clean side. If it's usually wet still, but you could re-dab it if you need it. I'm going to go ahead and I'm going to do another one. Go in, get really, really close to that stoma, wipe away. Okay. Keeping in mind that as I'm pulling that trach collar away, make sure the oxygen's fine. If I needed another one, I could go ahead and grab another gauze 2x2 here. Same deal. Fold it over. Dab, get underneath that flange here, wipe away. All right, fold back over, still wet, just using another cleaner edge, wipe away, and we're all good. If you end up having to use a lot of water, you dab that thing too much, at this point, sometimes I will take a dry, clean gauze 2x2, do the same approach and just kind of dry that side. You're going to put a drain sponge back behind there, which I'll show you here in a second. So it is going to absorb some of that stuff, but I don't like my drain sponge to get wet right off the bat necessarily, okay? So I'm going to go ahead and I throw these away here. So I don't put the drain sponge on yet. I do that kind of last here, okay? What we're going to do now is change the trach ties. So the one thing that really grosses me out is sticking my arms behind shoulders forward. That bothers me with BiPAP, bothers me with trach care. All right, so this is a little trick I do here. And all these trach ties, the ones we modern use, all right, they're Velcro. There's a bunch of different variations. It gives us the ability to pull this other little Velcro strap off and kind of customize the lengths and stuff. I start, unless I have a template and I know how long to make these ties for that patient, I always start out just like with my BiPAP mask, really, really loose, okay? You'll notice there's 2 pieces of Velcro on the outside of these patients' trach collars, okay? And I say it's important on the outside because you want to make sure these are oriented correctly. These pieces of Velcro are going to feed from behind that flange, go through those two little slits, and they're going to be what's responsible for holding that trach in place. So what I do to start out, I put a little loop like this on one end. And I just get in the habit, I kind of do it on both ends here. You might go, okay, why am I doing this? Well, I'm going to show you here. So what I do is I always put these loops in, and I'm going to use the old trach ties to feed through this loop and pull my new ones through so I don't have to put my arm back behind somebody's sweaty head. Let me see if I can set this guy up a little bit better so you can see what I'm doing a little more. Adjust this some. Okay, so what I'm going to do, I always leave this adjustable side. I try and leave it on my side. That way, if I'm going to make some fine-tuning adjustments, it's a little bit easier than trying to reach across them and stuff like that. So all I'm going to do, now it's essential, I'm going to take this old tie off, but once I do, you'll notice that I'm going to keep one finger on the flange at all times, okay? You don't want to do one of these and take your hands off because they can cough that trach up and out. On our next video, I'm going to show you how to change out a trach, so it's not a big deal, but you just want to generally get in the habit of actually managing and kind of securing that airway at all times, okay? We're respiratory. We got to be in charge of this stuff. So what I do now is I take my little loop, I feed this piece through that loop, okay? And then you can see I have it anchored on, okay? So now I don't got to go reaching back behind this patient's head or anything. I'm a little tied up in my trach collar here. So what I'm going to do, while holding this side, I'm going to go ahead, reach across. I'm going to pull the old ties, okay? And you'll see it's pulling my new ties through. Now you want to make sure you don't get any twists or anything like that. And once again, make sure you're keeping that flange nice and snug. So now I have the old ties out. I have my new ties around the patient's neck, okay? Now I've just got to secure stuff. So I go ahead, I'm going to start with kind of securing on my side here. And all I'm doing is undoing the Velcro, kind of running back in from behind and pulling, okay? Now these are awfully loose. This guy doesn't have a massive neck, so we're going to have to do some adjustment. So all I'm going to do here, I'm going to get the old ties out. Notice I'm keeping a finger on my flange at all times. Go ahead and pull that Velcro. All right, I'm going to undo this little loop I got, and I'm going to get rid of the old ties here. Okay, same deal. I'm going to run back and behind. I'm going to try to don't have any twists in my trach ties. And you got to remember, you're trying to keep that main part of the trach kind of from wiggling around, but you can kind of pull the flange up and out a little bit if you need to. So you can see that's way too loose. So what I'm going to do here, I'm going to use that other little fine-tuning piece of Velcro to make some adjustments. Now I'm going to intentionally leave this a little bit loose so I'm not fighting with my fat fingers to get the drain sponge in, okay? So right now this is way too loose. You shouldn't be able to fit multiple fingers back behind those ties. I've seen patients cough trachs out that are still attached to the ties and it's sitting on their chest because it was too loose. At the end, I like to be able to get one, maybe two fingers in a very, very, very snug fit, okay? Usually one of my fingers is tight enough. This is too loose, but that's intentional, and we'll tighten it up here at the very end, okay? So what we need to do next, if we had a Shiley tracheostomy tube, we would go ahead and you could change the inner cannula. I changed the inner cannula before changing the drain sponge, just in case they cough some stuff up or anything like that. The Bavona tracheostomy tube being made out of that siliconized material, it's not as likely to get the biofilm accumulation, so we don't have a removable inner cannula. It's a good thing about this trach, but it's also a bad thing because if something were to happen and this tracheostomy tube becomes plugged, we would end up having to completely exchange the tracheostomy tube, which once again in my next video, it's not a big deal, but it does add a different dynamic to things here. All right, if you did have a Shiley and you're changing that inner cannula, you need to make sure that you have an appropriate size inner cannula on top of that, or with all of your other supplies, okay? I'll shoot another video with some of the different trachs as we get into the review session for our practicum. But the Shiley inner cannulas, if you look, the package is always labeled, but it's going to have a little number embossed on the top part of that inner cannula and everything like that. And we'll make sure to point that out whenever we're in class together, okay? But I've been in situations where something happens when a trach plugs, you pull it out, you throw the inner cannula away, and you realize that the previous shift did not leave you a replacement inner cannula. So always verify that you have that ready to go and it's the appropriate size. If you have the wrong size, if you have an 8.0 intercannula for a Shiley and your trach is a 6, those are not going to fit. All right, they're dependent upon the diameter of that trach. So drain sponge, I call them split T sponges, drain T sponge, a split sponge. You want to make sure that you find something that is actually labeled and meant to go behind some sort of a tracheostomy tube. Some people use these on like G buttons and stuff like that. But it's essentially a pre-split it's a pre-split piece of gauze, multiple plies. All right, meaning there's multiple layers of this. Don't be chintzy and use one ply at a time. Most of these are 10 plies to the absorbency. You don't want to just start grabbing gauze 4x4s and cutting them yourself, because what happens is you get a very unfinished edge, and those little pieces of fiber can come out. They can embed themselves in that stoma and can be a problem. If you do have things that get embedded in the stoma, a lot of the medicine carts and the patient's room supply carts, you can get little Q-tips or cotton tip applicators, and you can roll those around the inner edge of that stoma and pull stuff out so you're not reaching in with gauze. That's usually not a major issue, but if you do get something, or even secretions or some blood or something that you're trying to work out, you could use that. But make sure you got something like this. This is going to go back behind the flange, okay, and kind of insert and envelop itself around the actual outer cannula of the trach itself. So what I do is I get this thing and I set it right like that on the front, okay, first. And then all I do, I kind of pull that flange forward. I kind of slip one side up, and I kind of pull and want to get all the wrinkles out and stuff like that. I don't want to get that back behind the neck and there be a bunch of creases in that split sponge or anything, because I would think that'd be uncomfortable. I'm going to go ahead, I'm going to finish with this other side here. And then you just want to make sure, once again, we got all the little creases out. Everything looks nice. And that the purpose of that is going to absorb some of the secretions that come out around there, and it's going to help us kind of keep stuff clean and everything like that, opposed to stuff just draining out on the chest and sitting there and causing irritation. So it makes a barrier between the trach and our skin ourselves. So last order of business here as far as the site care goes, okay, is tightening these things up. These are still too loose. I shouldn't be able to get fingers in that easily. So I'm going to pull that little tab that I conveniently left on my side. And I'm going to kind of pull this really, really snug. All right. And now you can see I can kind of slip one finger in, and I got fat fingers. Okay. That's a little bit better there. The patients are typically going to let you know if it's too snug. Don't go crazy and cut off circulation or anything, but you don't want that airway to come out. It should be able to have nice, feel nice and anchored if any sort of manipulation occurs. So I go ahead and finish up with a little assessment here. Okay, listen to breath sounds, make sure it doesn't need to be suctioned again, make sure everything looks good. I chart my stuff, I get it cleaned up. I'm going to go ahead and I turn down his FiO2 to what he was at previously. I don't want you thinking that I bump up everybody's FiO2 during trach care, because I don't, okay? But if you got somebody you're suctioning out, or you're worried about having to take that trach collar off for a prolonged period of time, it's not going to hurt a majority of our patients unless they're in end-stage COPD or something like that. Okay, so make sure, once again, with all our checkoffs, you're returning that patient back to whatever they were on previously and resuming previous therapy. So make sure you don't leave them on that increased FiO2 if you did bump them up. Once again, cleaning up. I like to try and take care of my next shift, or whoever's following me, or whether it's me coming back in the room or somebody else, making sure you got an appropriate supplies for your next shift to be able to carry out trach care and everything like that. All right, so that is the abridged version of trach care. Let me show you one other thing. You might work at a facility. I've only come across a few. It gives you this handy dandy little preformed trach care kit. Okay. The nice thing about the trach care kit, if you open this up, it comes with a sterile base in itself. So this is great for pouring your sterile water in for site care. Okay. It actually gives you a set of sterile gloves and suction catheter. All right. It's got a little sterile base in it, like not all of them have this, but it's got like a little top you need to set stuff up and out. If you're changing a trach or something like that. It comes with the little cotton tip applicators I was talking about, so we could swirl those around the outer part of the stoma and get little pieces of debris out or anything, or clean up secretions from that inner edge if need be. Okay. The one other cool thing, it comes with a little pipe cleaner brush. This is great if you're cleaning out somebody's tracheostomy tube itself. Okay. We don't repurpose those disposable intercannulas from a Shiley. But if I was doing a trach change and pulling somebody's bavona out, I could go ahead and I could put that trach in a little sterile basin and clean that tracheostomy tube out. If I am cleaning a trach, I do use a little mix of sterile water and hydrogen peroxide, just because they're cleaning up, once again, just not on my stoma or anything like that. Don't do this. I've seen a couple of people, not respiratory, won't say what profession. All right. But I've seen people go, oh, let me get that trach clean and start putting a wire brush down in your trach. All right. We don't stick these things in people. All right. This is for when that tracheostomy tube comes out. When you think about a lot of our patients with like laryngectomy and Larry tubes and some of the things we'll talk about here in subsequent lessons, these are great for being able to clean the tubes itself and everything, but that's with it out of the patient. Okay. So sometimes the only place you can really find these little brushes is in these Trach Care kits if your hospital has one. They do come with some gauze. It's going to give you your split sponge or your T-sponge, strain sponge, whatever you want to call it, and a bunch of gauze 4x4s as well. It's going to give you some twill ties. I don't use twill ties or anything like that. If you get in a bind, you can put a little surgeon's loop and kind of pull it in snug and everything. But we're not really going to be doing that or anything. Okay, so you can kind of disregard these ones. I getting able to do this without a Trach Care kit. That way, if you have one, you're pleasantly surprised. But if you're at a place where you don't, which has been a majority of the place I've been, you're not going to be in a bind. You're going to be able to kind of work your way through stuff. All right, last order of business before you leave, and really even before you start to do some of these patients, you should always have a tracheostomy emergency bin. So having a spare airway, an obturator, lubricant, suction catheters, all your Trach Care stuff, ambu bag, making sure all those emergency supplies you guys talked about in lecture component are available. All right, so that is Trach Care for a Bavona tracheostomy tube. The only difference with this Shiley is, once again, we would change that inner cannula out. And that's something we can kind of play around with in class. With the Shiley tracheostomy tubes, once again, you have the clips on the side for most of them. There's a couple other variations. All you would do is kind of push, pull on those clips. I try and pull out and away and follow that normal curvature instead of trying to pull up and torque that airway. You pull this up and out. You can see, if you look really, you probably can't see it actually, but there's a little number embossed on the top there. That should be the same size as what my flange says I have and everything. And then when you put that tracheostomy, that inner cannula back in that trach tube, push, and then make sure you got a firm click and lock up, okay? Bad part about the Shileys is if you take that out, if I go, oh, it's bad, and I threw it away, and they're on a ventilator, you lose your 15-millimeter adapter, and you can't hook up any of your life support equipment. You can't hook into a ventilator, ambu bag, anything like that, okay? So it's essential that you make sure you have placement inner cannula, and all you do, kind of follow that same curvature, push it, click, make sure you're good. And that's it, guys. I'll show you my trach change video here in a second.